Let's discuss the case of Ebola virus disease. A 36-year-old male healthcare worker presents to the emergency department with high-grade fever of 39.5 degrees Celsius that began 1 day ago. This is an acute presentation requiring immediate attention. The crucial epidemiological detail is that this patient recently returned from East Africa, where he was providing medical assistance during an infectious disease epidemic. This travel history to an endemic area immediately raises suspicion for viral hemorrhagic fever, particularly Ebola. His occupational history is significant. As a healthcare worker dealing with an epidemic, he had direct contact with infected patients. He reports that many of his patients presented with fever, constitutional symptoms including severe fatigue, weakness, muscle pain, and headache, and a characteristic skin rash that was prominent on the trunk. This rash pattern is typical of viral hemorrhagic fevers. Most alarming is the outcome he observed. The majority of his patients died from multiple organ failure, including shock from severe fluid loss and cardiovascular collapse, hemorrhage with uncontrolled bleeding, coma from cerebral involvement, and renal failure indicating multi-organ system collapse. This high mortality and clinical pattern strongly suggests Ebola virus disease. Appropriate infection control measures were immediately implemented. Blood samples, blood cultures, and sputum samples were collected, following strict biosafety protocols, and sent to specialized reference laboratories equipped to handle highly infectious pathogens. This case illustrates the importance of obtaining detailed travel history, occupational exposure, and contact history when evaluating patients with fever, particularly in healthcare workers returning from epidemic areas. Early recognition and isolation are critical for patient care and preventing nosocomial transmission. Ebola virus belongs to the family Filoviridae, and filovirus virions, which are complete viral particles, are pleomorphic. This structural variability is unusual among viruses. The characteristic shapes of Ebola virus are distinctive as long, sometimes branched filaments. This filamentous, thread-like appearance is what gives filoviruses their name. Philo comes from the Latin word for thread. Ebola virus is an enveloped virus, possessing a lipid bilayer membrane surrounding the nucleocapsid. This envelope is derived from the host cell membrane and is studded with glycoprotein spikes, particularly the GP protein, which is essential for viral attachment to host cells and is the primary target of neutralizing antibodies. The genome consists of single-stranded RNA. Viral replication occurs in the cytoplasm of host cells. Ebola virus belongs to the order Mononegavirales, and family Filoviridae is divided into 2 genera. The first genus is Ebola virus, which contains 5 distinct species. The second genus is Marburg virus, containing 2 species. Within the genus Ebola virus, there are 5 species, each named after the geographic region where they were first identified or caused outbreaks. Zaire Ebola virus is the most virulent species, causing the highest mortality rates, often exceeding 80 to 90% in some outbreaks. This was the species responsible for the devastating West Africa epidemic of 2014 to 2016. Sudan Ebola virus causes severe disease, with mortality rates of 40 to 60%. Bundibugyo Ebola virus was first identified in Uganda and has mortality rates around 30 to 40%. Thai forest Ebola virus has caused only 1 known human case. Reston Ebola virus is unique because it has caused disease in non-human primates, but appears to be non-pathogenic in humans, though humans can be infected asymptomatically. The genus Marburg virus contains 2 species. Marburg virus or Marburg van Raven virus both cause Marburg virus disease, which is clinically similar to Ebola but caused by a distinct virus. The 2014 to 2016 Ebola outbreak in West Africa was the largest and most complex Ebola epidemic in history, fundamentally changing our understanding of Ebola's epidemic potential and highlighting critical gaps in global health security. The outbreak primarily affected multiple countries in West Africa, specifically Guinea, Liberia, and Sierra Leone. These 3 countries bore the overwhelming majority of cases. Limited cases also occurred in Nigeria, Mali, and Senegal, though these countries successfully contained their outbreaks. Healthcare workers from affected countries who traveled internationally caused isolated cases in the United States, Spain, and the United Kingdom. The scale was unprecedented. Over the duration of this epidemic from December 2013 to June 2016, there were 28,616 suspected, probable, and confirmed cases reported from the 3 most affected countries. Of these, 11,310 deaths occurred, yielding an overall case fatality rate of 39.5%. This represents the deadliest Ebola outbreak in history, with more cases and deaths than all previous Ebola outbreaks combined. Several factors contributed to this epidemic's magnitude. It began in a forest region with traditional burial practices involving touching the deceased, which is extremely high risk for transmission. Initial cases were not recognized as Ebola, allowing unchecked spread. The affected countries had weak health systems, decimated by recent civil conflicts. High population density and mobility between Guinea, Liberia, and Sierra Leone facilitated regional spread. Cultural practices, including traditional healing and burial rituals, accelerated transmission. Healthcare worker infections were particularly devastating, with over 500 healthcare workers dying, further weakening the response capacity. The international response eventually mobilized unprecedented resources. The epidemic was finally controlled through massive deployment of Ebola treatment units, contact tracing teams, safe burial teams, community engagement changing burial practices, and deployment of international medical teams. This diagram illustrates the hypothesis of Ebola virus transmission at the human-animal interface, showing the complex ecology of the zoonotic disease. The natural reservoir of Ebola virus is believed to be fruit bats. These bats can carry Ebola virus asymptomatically without becoming sick themselves. The virus maintains a cycle within bat populations through unknown mechanisms, possibly involving bat-to-bat transmission. Spillover to other animals occurs when bats shed virus in saliva, urine, or feces that contaminate fruits or other materials. Non-human primates, including gorillas, chimpanzees, and monkeys, can become infected by consuming contaminated fruits or through contact with infected bat secretions. These primates develop severe, often fatal disease similar to humans. Other animals that can be infected include forest antelopes like duikers and porcupines. Human infection typically begins through contact with infected animals in what's called an index case, or patient zero. This can occur through several routes. Hunting and butchering infected animals, particularly primates or bats, is a major risk. The virus enters through cuts or mucous membranes during contact with infected blood or tissues. Consuming bushmeat from infected animals can cause infection. Contact with bat droppings or partially eaten fruits in caves or forests may transmit virus. Once the virus enters the human population, human-to-human transmission becomes the dominant transmission mode. This occurs through direct contact with blood, secretions, organs, or other bodily fluids of infected people. Indirect contact with contaminated materials like bedding or clothing can transmit virus. Traditional burial practices involving washing and touching the deceased are particularly high risk because viral loads are highest at death. This slide on pathogenesis of Ebola virus disease shows how the virus systematically attacks the body and the clinical progression from early symptoms to fatal complications. Ebola virus simultaneously disables two critical systems, the immune system and the vascular system. The virus first infects dendritic cells and disables the interferon system, which is the body's first-line antiviral defense mechanism. This immunosuppression allows unrestricted viral replication. Simultaneously, macrophages become infected. These infected macrophages trigger a cytokine storm, releasing massive amounts of inflammatory proteins, including tumor necrosis factor and interleukins. They also produce nitric oxide, which damages blood vessel linings. Third, the virus infects endothelial cells lining blood vessels. This causes leakage of blood from vessels into tissues, leading to hypotension and dramatic drop in blood pressure, ultimately resulting in shock. The virus affects multiple organs. In the liver, it destroys production of coagulation proteins, causing uncontrolled bleeding. In adrenal glands, it destroys cells that make steroids, leading to circulation failure and disabled regulation of blood pressure. The gastrointestinal tract is affected, causing severe diarrhea. Clinically, this manifests in stages. Early-stage symptoms include sudden onset of fever, intense weakness, muscle pain, headache, and sore throat. These are followed by vomiting, diarrhea, rash, impaired kidney and liver function, and both internal and external bleeding from multiple sites, including eyes, ears, nose, and gastrointestinal tract. This diagram shows Ebola virus's typical path through a human being over time, illustrating the rapid deterioration from first symptoms to death in just days. Day 7 to 9 represents first symptoms. The circles highlight affected areas. Headache affects the head, fatigue causes whole body weakness, fever develops systemically, and muscle soreness particularly affects the limbs. At this stage, patients may present like common flu, making early diagnosis challenging. Day 10 shows dramatic worsening. The entire body becomes affected. Sudden high fever spikes, often exceeding 39 to 40 degrees Celsius. Vomiting begins, and critically, patients may start vomiting blood, indicating gastrointestinal hemorrhage. Passive behavior develops as patients become increasingly lethargic and unresponsive. Day 11 marks the hemorrhagic phase. Bruising appears throughout the body, visible as the darker patches, indicating subcutaneous bleeding. Brain damage begins from vascular compromise and inflammation. Bleeding manifests from multiple orifices: nose, mouth, eyes, and anus. This represents the classic hemorrhagic fever presentation, with blood appearing from every body opening. Day 12 represents the final stages for those who will not survive. The dark coloring indicates multi-organ failure and circulatory collapse. Loss of consciousness occurs as the brain is affected by hypoxia and inflammation. Seizures may develop from cerebral involvement. Massive internal bleeding affects all organs. Without intensive support, Death typically occurs from hypovolemic shock, multi-organ failure, or complications like aspiration. The timeline shows the frighteningly rapid progression, from first symptoms to potential death in just 5 days. This short timeline explains why early recognition and supportive care are critical, though even with best care, mortality remains high with certain Ebola species. When Ebola virus disease is suspected, immediate and strict protocols must be followed to protect healthcare workers, laboratory staff, and the community while ensuring proper diagnostic testing. These procedures are critical and non-negotiable. The first critical step is collection and shipment of specimens following strict biosafety protocols. Specimens from suspected Ebola cases are classified as Category A infectious substances, requiring the highest level of safety precautions. Immediately inform the National Reference Laboratory before collecting specimens. This ensures they're prepared to receive and process highly infectious materials safely. In Malaysia, this would be the National Public Health Laboratory under the Ministry of Health. Provide detailed clinical and epidemiological information so the laboratory can implement appropriate safety measures. Healthcare workers must wear personal protective equipment, or PPE, correctly to avoid any risk of contamination when taking specimens. This includes double gloves, fluid-resistant gowns, face shields or goggles, N95 respirators or higher, and shoe covers. Every step must follow established protocols with buddy system monitoring to ensure no breaches in technique. Collect the required specimens in accordance with procedures described in WHO guidelines. For Ebola, this typically includes whole blood and EDTA tubes, serum samples, and possibly throat swabs. Specimens should be collected with extreme caution, using safety-engineered devices to minimize sharp injuries. The specimens must be packaged using triple packaging requirements as mandated for Category A infectious substances. The primary container holds the specimen in a leak-proof, labeled tube. The secondary container is a durable, watertight container with absorbent material capable of absorbing all fluid if the primary container breaks. The outer shipping container is rigid and properly labeled with biohazard and Category A markings. Relevant clinical and epidemiological information must be attached to the laboratory request form, enclosed with specimens. This includes patient demographics, symptoms, exposure history, travel history, and clinical findings. This information helps laboratories prioritize testing and interpret results. A case is considered positive or confirmed when the laboratory has demonstrated recent infection with Ebola virus using one of several accepted techniques. Multiple testing methods exist because no single test is perfect, and different tests are useful at different disease stages. Antigen detection using ELISA test identifies viral proteins in blood samples. This can detect infection during the acute phase, when viral loads are high. It's relatively rapid but may be less sensitive early in infection. Detection of IgM antibodies directed against Ebola virus indicates recent infection. IgM antibodies appear around days 2 to 9 of illness and suggest current or very recent infection. However, early in illness before antibody development, IgM may be negative despite active infection. Seroconversion or increasing IgG antibody titers in 2 subsequent specimens collected within a week of each other confirms recent infection. IgG appears later than IgM and persists long-term. Seeing IgG rise or convert from negative to positive definitively proves recent infection. Detection of virus RNA by reverse transcription polymerase chain reaction, or RT-PCR, is currently the gold standard for Ebola diagnosis. RT-PCR can detect viral RNA as early as day 3 of symptoms and remains positive throughout the acute illness. It's highly sensitive and specific. Sequencing of PCR products can identify the specific Ebola virus species. Detection by immunohistochemical or IHC staining of patients' tissue or blood identifies viral antigens in cells using specific antibodies. This is particularly useful for post-mortem diagnosis. Viral isolation by tissue culture involves growing live virus from patient samples. This definitive method confirms viable virus presence but requires biosafety level 4 facilities and takes several days. It's primarily used for research rather than clinical diagnosis. A negative test early in illness doesn't rule out Ebola. If clinical suspicion remains high, repeat testing 72 hours later is recommended. Conversely, a positive result requires immediate notification of public health authorities and implementation of strict isolation protocols. Healthcare workers are at extremely high risk during Ebola outbreaks, as evidenced by the hundreds of healthcare worker deaths during the West Africa epidemic. Strict adherence to infection prevention and control measures is literally life-saving. Standard, contact, and droplet precautions must be meticulously followed. Standard precautions apply to all patients and include hand hygiene, appropriate PPE use, and safe handling of sharps. Contact precautions prevent transmission through direct or indirect contact with patient or environment. Droplet precautions prevent transmission of large respiratory droplets. A single patient room is strongly preferred, ideally with a dedicated bathroom. This isolation prevents contact with other patients and limits environmental contamination. The room should have minimal equipment and furniture to facilitate cleaning and reduce contamination risk. Several critical elements require special emphasis. Use of sharp safety devices and safe work practices is paramount. Needle stick injuries with Ebola-contaminated sharps can transmit infection. Safety-engineered devices with retractable needles or needleless systems should be used whenever possible. Sharps disposal containers must be readily accessible. Recapping needles is strictly prohibited. Hand hygiene is the single most important infection prevention measure. Hands must be cleaned before and after every patient contact, after removing gloves, and after any contact with potentially contaminated surfaces. Alcohol-based hand sanitizer with at least 60% alcohol or soap and water are both effective. When hands are visibly soiled, soap and water must be used. Barrier protection against blood and body fluids must be worn upon entry into the patient's room, before any patient contact. This includes single gloves initially, though double gloving may be used for additional protection. A fluid-resistant or impermeable gown prevents contamination of clothing and skin. Face and eye protection with masks, goggles, or face shields prevents splash contamination of mucous membranes. Every piece must be donned in the correct sequence and removed carefully to avoid self-contamination. Appropriate waste handling is critical because all materials from Ebola patients are potentially infectious. All waste should be treated as Category A infectious waste. Contaminated materials must be placed in leak-proof, puncture-resistant containers, then into a second container for safe disposal. Waste should be incinerated or autoclaved before disposal. Laundry should be handled minimally, placed in leak-proof bags, and disinfected before washing. N95 or higher respirators must be worn when performing aerosol-generating procedures. While Ebola primarily spreads through contact rather than true airborne transmission, certain procedures can generate aerosols containing infectious particles. These include intubation, bronchoscopy, suctioning of airways, and cardiopulmonary resuscitation. During these procedures, N95 respirators or powered air purifying respirators or PAPRs provide respiratory protection beyond surgical masks. A critical point is that the largest viral load occurs in final stages of illness when hemorrhage may occur. As patients deteriorate, viral replication reaches maximum levels. When hemorrhagic manifestations occur with bleeding from multiple sites, environmental contamination with highly infectious blood becomes extreme. This is the most dangerous period for healthcare workers, requiring maximum vigilance. Additional PPE may be necessary, especially in resource-limited settings. This includes double gloving, with an outer pair of long cuff gloves extending over gown sleeves. Leg coverings or shoe covers prevent contamination of lower extremities and footwear. In settings where options for cleaning and laundry are limited, disposable items may be preferred despite higher costs. Waterproof aprons can be worn over gowns for additional protection during high-risk procedures. Trained observers should supervise PPE donning and doffing to ensure proper technique and identify any breaches. A buddy system where two healthcare workers monitor each other is ideal. PPE removal is actually more dangerous than donning because contaminated surfaces must be carefully handled without touching skin or mucous membranes. As future healthcare providers, you must understand these principles because Ebola outbreaks can occur anywhere through international travel, and your knowledge and adherence to protocols may literally save lives, including your own. Thank you for your attention.